Some people who use Ozempic or similar weight loss medications report changes in their vision. At the same time, research has shown that in one large study, people with obesity and colon cancer who used these medications had a dramatically lower risk of dying from that cancer. In that study, on the order of 62% lower, compared to those who did not. That kind of finding suggests these drugs may do more than help with weight and blood sugar. So which is it? Are these drugs a medical revolution or a disaster waiting to happen? In this video, we will look at the science, the history of weight loss drugs, the real benefits that studies have found, and the risks that your doctor may not emphasize enough. If you are already using one of these medications or are considering them, this information can help you make a more informed decision. Let us start with what we are talking about. Ozempic, Wegovy, Mounjaro, and Zepbound are injectable medications often called weight loss pens. They belong to a class of drugs known as GLP-1 receptor agonists. GLP-1 is a hormone that your own gut produces when you eat. These medications increase the effect of that hormone in your body. They are approved for treating type 2 diabetes, and in higher doses, for weight management in people with obesity. Millions of Americans now use them. And because so many people are on these drugs, understanding both the benefits and the risks matters more than ever. Whether you are already on one of these medications, thinking about starting, or know someone who is, having clear and balanced information helps. This video will not tell you whether to take these drugs or not. That decision is between you and your doctor. But it will give you the context you need to ask better questions and to understand what the research actually says. Before we get to how these medications work, we need to address a persistent myth. The myth that obesity is simply a lack of willpower, that if you just eat less and move more, the weight will come off. Research over the past decades has shown that this view is incomplete and often harmful. Body fat is not just stored energy. It functions like an active organ, releasing dozens of chemical signals that affect your appetite, your metabolism, and your brain. When fat tissue grows beyond a certain point, it can promote chronic inflammation throughout the body. That inflammation can reach the brain, including the hypothalamus, the region that helps regulate hunger and fullness. In many people with obesity, the brain stops responding properly to the signal that says you have had enough to eat. It is similar to what happens in type 2 diabetes with insulin. The hormone is there, but the body becomes resistant to it. So the person is not overeating because they are weak or lazy. They are fighting a biological system that is no longer responding the way it should. This does not mean that diet and exercise are useless. They still matter. But for many people, they are not enough on their own. The brain's set point for weight has shifted, and changing that set point often requires more than willpower. If you have ever felt guilty for not being able to stop eating when you knew you should, that guilt may be misplaced. The problem is often biology, not character. Understanding this is important because it explains why simply telling someone to eat less has failed so often, and it sets the stage for why the newest weight loss medications work differently. Now, a brief look at history. Over the past century, several drugs were promoted as miracle solutions for weight loss. Almost every time serious problems emerged in the 1930s, a chemical called dinitrophenol was used in explosives. Workers exposed to it lost weight because it sped up their metabolism. It was sold as a weight loss drug. The result: severe side effects including blindness, nerve damage, and in some cases death from dangerous rises in body temperature. It was eventually classified as poison. In the 1940s and 1950s, amphetamines were used to keep soldiers alert. After the war, they were marketed for weight loss. So-called rainbow pills combined amphetamines with thyroid hormone, diuretics, and laxatives. By 1970, millions of Americans were taking some form of amphetamine for weight loss. The consequences included addiction, psychosis, heart rhythm problems, and deaths. In the 1990s, a combination of two drugs, fenfluramine and phentermine, known as Fen-Phen, became extremely popular. It worked. People lost a lot of weight quickly. At its peak, tens of millions of prescriptions were written in the United States alone. Then reports began to surface. Young, healthy women with severely damaged heart valves. Others developed life-threatening lung disease. Fen-Phen was withdrawn from the market. The manufacturer paid billions of dollars in settlements. The story of Fen-Phen is a cautionary tale. A drug that seemed to work wonders until the true cost became clear. Later, other drugs followed a similar path. Zepbound was withdrawn when it was linked to increased heart attack and stroke risk. Ephedra was banned after reports of heart attacks and seizures. Rimonabant was pulled when it was linked to severe depression and suicide risk. Each of these drugs had a different mechanism, but the pattern was similar. Initial excitement, widespread use, then serious harm that led to withdrawal or strict limits. So when a new weight loss drug arrives, it is reasonable to ask, why would this time be different? The answer lies in how the new medications work. They do not blast your brain with stimulants. They work with a hormone your body already makes. Here is the crucial shift in how we understand obesity. Scientists discovered that obesity is not primarily a problem of the stomach or of willpower. It often starts in the brain. Your fat tissue produces a hormone called leptin. Leptin tells your brain when you have had enough to eat. In many people with obesity, leptin levels are high, but the brain does not respond properly. It is like shouting at someone who is wearing headphones. The signal is there, but it does not get through. This is called leptin resistance. GLP-1 is another hormone involved in the same conversation. Your intestine releases GLP-1 when you eat. It does three main things. It signals the pancreas to release insulin. It slows the emptying of your stomach, and it tells your brain that you are full. The weight loss pens increase the level or effect of GLP-1 in your body. Think of the difference like this. The old amphetamine-based drugs were like using a sledgehammer on your brain to force down hunger. They worked, but they damaged the system. GLP-1 medications are more like adjusting a thermostat. You are not breaking anything. You are helping regulate a system that already exists. You are strengthening a signal your body is supposed to send but has stopped sending clearly. So does it work? Yes, studies consistently show that these medications can lead to significant weight loss and better blood sugar control in many people. But the benefits may go beyond weight and diabetes. Research has looked at heart outcomes. A large analysis published in a major cardiology journal looked at tens of thousands of patients with diabetes, obesity, or cardiovascular risk. Those on GLP-1 medications had lower rates of death from any cause, fewer heart attacks, and fewer episodes of heart failure. The size of the benefit varied by trial and by drug, but the overall picture from meta-analyses is that these medications may reduce the risk of serious cardiovascular events in the population studied. The benefit appeared in people with diabetes, with obesity, and in some with existing heart or kidney problems. This has led many cardiologists to view GLP-1 medications not only as weight or diabetes drugs, but as part of comprehensive cardiovascular risk reduction for certain patients. Cancer has also been studied. One study analyzed tens of thousands of patients and found that those who used GLP-1 medications had a lower risk of developing several types of cancer compared to those who did not. Another study focused on people with obesity and colon cancer. Those who used GLP-1 medications had a much lower risk of dying from that cancer over the follow-up period compared to those who did not. The magnitude of the effect in that colon cancer study was striking enough that researchers and clinicians have taken notice. It does not prove that the drugs cause the better outcome. Observational studies have limits, but the association is consistent with the idea that reducing obesity and improving metabolic health may improve cancer outcomes. The exact numbers vary by study, but the direction is consistent. In these trials, use of GLP-1 was associated with better outcomes. More research is needed to confirm cause and effect and to see which patients benefit most. Scientists think that reducing obesity and inflammation may remove some of the fuel that cancer cells use to grow. There may be benefits for the liver as well. Some of these medications have been shown to reduce fat in the liver, which can lower the risk of serious liver disease. Sleep apnea, which is common in people with obesity, may also improve with weight loss on these drugs. And in an unexpected finding, some research has suggested that people on GLP-1 medications may have fewer alcohol-related hospitalizations. The same brain circuits that regulate hunger and reward may be involved in addictive behaviors, so regulating one may affect the other. This is still an area of active research, so the picture so far is impressive. Weight loss, better blood sugar, possible heart and cancer benefits, liver and sleep benefits, but there is another side. We need to talk about the risks first. Vision. Some users of semaglutide, the active ingredient in Ozempic and Wegovy, have reported vision problems. There is a condition called anterior ischemic optic neuropathy, in which the optic nerve does not receive enough blood. A study from Harvard found that users of semaglutide may have an increased risk of this condition. Especially in the first year of use, the risk is still relatively rare. Estimates suggest it may affect roughly 1 in several thousand users per year. The Harvard study suggested that the risk might be on the order of 2 to 4 times higher in users of semaglutide compared to users of a different type of diabetes medication, though the absolute risk remained low. But when millions of people use a drug, even a rare risk can add up to many affected individuals. So even if the chance is small for any one person, it is worth being aware of and watching for symptoms. If you notice any changes in your vision while on these medications, You should see your doctor or an eye specialist promptly. Second, and this is critical, drug interactions. GLP-1 medications slow down how quickly your stomach empties. That is part of how they help you feel full. But a slower stomach can change how well other medications are absorbed. Some drugs need to be absorbed at a steady, predictable rate to work safely. These include certain anticonvulsants used for epilepsy, anticoagulants used to prevent blood clots, and other medications with a narrow therapeutic window. There have been reports of people whose other medications stopped working as expected after they started a GLP-1 drug. For example, someone whose seizures were well controlled might have a seizure when the level of their anticonvulsant in the blood becomes erratic. Someone on an anticoagulant might be at higher risk of a clot if the absorption of their blood thinner becomes inconsistent. This is not always highlighted in the main advertising for these drugs, but it is real. If you take any prescription medication, especially for epilepsy, blood clots, or other serious conditions, you must talk to your doctor before starting Ozempic, Wegovy, Mounjaro, or similar drugs. Ask specifically, could this affect how my other medications are absorbed? That conversation could prevent a serious complication. Now, the question many people ask, will I have to take this for the rest of my life? The honest answer is probably yes. If you want to maintain the benefits, research has shown what happens when people stop. A study published in the British Medical Journal followed thousands of people who stopped taking GLP-1 medications. On average, they regained weight. The rate varied by drug. But over time, much of the lost weight often came back. In some analyses, people regained on the order of roughly half a kilogram per month or more after stopping, so that within a year or two, a large portion of the weight loss could return. Within about 2 years, many people were close to their original weight. This is why experts often say that obesity is a chronic condition that may require long-term treatment, not a short-term fix. This is not a flaw of the medication. It reflects how obesity works. When the medication is gone, the biology that drives weight gain is still there. You do not expect someone with high blood pressure to take a pill for a year and then have normal pressure forever without treatment. We do not expect someone with type 1 diabetes to stop insulin once their sugar is under control. Obesity is a chronic condition. For many people, managing it requires ongoing treatment. Calling these medications a crutch misses the point. They are a tool that helps the body regulate what it is already supposed to regulate. So, where does that leave us? Are these drugs a revolution or a disaster? Neither. They are the first time medicine has had a class of weight loss drugs that work by targeting the brain's regulation of appetite with a hormone the body already uses. They are not magic. They have real risks, including vision changes and the potential to affect how your other medications work. They are not poison. They have real benefits for weight, blood sugar, and possibly for heart disease, cancer risk, and more. They are a powerful tool that needs to be used with knowledge. If you are considering starting one of these medications, talk to your doctor about your full medical history and every other drug you take. If you are already on one, do not stop or change the dose without medical guidance. And if you take anticonvulsants, anticoagulants, or any medication where consistent absorption is important, ask your doctor explicitly whether GLP-1 therapy could affect them. This video is for educational purposes only. It is not medical advice and does not replace a conversation with your healthcare provider. We are not recommending for or against these medications. Every person's situation is different. If you have questions about weight loss medications, drug interactions, or your vision, speak with your doctor. If you think you are having a serious side effect or a medical emergency, seek care immediately. Take care of yourself, and make sure you have the information you need to make the best decision for your health.